Yeah, this is a talk in which in a few different lives I've given to different contexts, including some specialists, some pediatricians, some nurses, some general public, some GPs, in a variety of different ways. And it kind of touches on the stuff that I do pretty much every day, which is trying to convince parents that they should be compliant with the medications that we'd like them to use in particular for their eczema, and that they often wouldn't be avoiding the foods that we don't think they need to avoid. And so there's a lot of spiel goes into trying to give those parents a bit of some evidence-based background to what we're trying to do, but in a way that spins stories, really. And so this is some evidence and some concept, but without a lot of the technical jargon, I hope, that we would usually bring to some of the immunologic topics that we talk about. So what is allergy, and why is there an allergy epidemic? There is an epidemic. I think we can be pretty certain of that. These are Australian data from, came out I think last year or the year before from the Health Nut study in Melbourne, and what you can see is in the first year of life, 11% of the general population will have a food allergy of some sort. The majority will outgrow that. So by the age of 4, you'll see that a food allergy is just under 4%. But nonetheless, the statistics have been going up, and the best followed up cohort in the world is the Isle of Wight study, and the rates of sensitization and true allergy have been going up over time in Isle of Wight. And so we think that's generally reflected elsewhere, and Australia is one of the leaders in the world in terms of our prevalence of allergy. So a little bit of concept, and I think this is important in terms of then trying to go on and explain to yourself, explain to parents what it is and why we get these allergies and what it is that causes them and what we can do. So innate and adaptive immunity. We have innate and adaptive in other areas as well. So these two little fellas, if this fella grew up on an island, he would learn to walk on his own. But if he grew up on an island, he wouldn't learn to speak English. And so we have some skills which are innate, that you learn them irrespective of where you are, and some you have the background ability to adapt to your environment and learn other skills, such as a particular language. So the immune system is pretty much the same. It also has an innate wing, which just goes into action straight away. We're all born with that. And it has an adaptive wing where it has to say, what is this thing, in particular, what is this foreign thing, and is it dangerous or is it harmless? And so those are the questions that we have. And immune recognition is where we get allergy. It's a failing of immune recognition. And so sometimes we use analogies, and in fact, sort of surveillance and military and police analogies are quite good ways of looking at the immune system, because it's asking pretty much the same questions. If we were thinking about a threat, we might have this really obvious threat, like a big army that's about to launch at us. And we might have specific, very direct ways of responding to that. We have some processes in place that would go immediately into action, and our army, our effective function, would come straight back at that. But you also might have a threat that was hidden somewhere in a crowd. Somebody in that crowd might be a threat to you, and then you would have to adapt and use all of the other circumstances at your ability to then identify who that person might be and to respond to that person. I don't know why I put a policeman there, but the analogy kind of ran out of steam. And so it's very similar with the immune system. If we have an old-fashioned bug that we've evolved with, like this is E. coli, and E. coli can't do much more to hide from us. It has some mechanisms, but it's been with us since forever. We know how to deal with it. It knows how to deal with us. And so in general, we have particular responses to E. coli, and so those kick in as soon as we become exposed to it. But HIV down the bottom here is a very different thing. That's something that we haven't evolved with. That kind of emerged into humans, or crossed into humans in the last 50 or 60 years. And so we had to adapt to that, and we haven't adapted very well to HIV. But we do lots of producing antibodies and stuff that are specific to HIV, and that's us adapting to something new. And so adaptation to bugs is really, really important. But sometimes we can get that wrong, and we can adapt and we can respond either to bits of ourselves or to something that's foreign but doesn't really bother us at all. It shouldn't bother us, like a food or a pollen, things we shouldn't react to. They're not infectious. So allergy is when the adaptive immune system makes a mistake It misinterprets those signals about something that it's seeing. It classifies that something harmless as being dangerous. It mounts an aggressive response, and there are deleterious consequences for us, the host. So I'm going to take you through a little bit of a customs and excise sort of exercise in order to just demonstrate how that might work and how the immune system might make mistakes. So if we take Bindi here, and we'll have to be a little bit closed because I know people would say, well, Bindi's not one of us, but she's not natural. But we could all probably assume that Bindi's an Aussie. And if you were to look at this photograph, you'd say Bindi's a teenage girl there, and you'd have to be pretty cynical not to innately recognize that she doesn't offer a threat, that she's harmless. And so Bindi is self and innately recognizable as being harmless. Although if you have a teenage daughter, which I do, you'd probably rather take on Godzilla. Godzilla, on the other hand, is he's foreign because he's Japanese. But he's also an 80-foot tall lizard. And so we would innately recognize an 80-foot tall lizard as being a threat. That would be something that would strike us immediately. So he's foreign, and he's innately recognizable as dangerous. So that side is pretty easy to pick up. But this gentleman down in the right-hand corner here, he's a little bit more difficult because actually we saw lots of images of him before we eventually figured out that he was a bad character. And if you look at his image, you kind of think, oh, he actually could look quite sweet. He's obviously foreign, or fairly obviously foreign, but he's got a kind of feminine face. He looks a little bit soft, really. And then we all figured out he was bad because we had something to tell us from the environment. We had an adjuvant to tell us that this is a bad thing and we should react badly to this. And the adjuvant was pictures of planes flying into buildings, which is something we pretty much all innately or should innately recognize as being a bad thing. So we all cottoned on to him, but we had to adapt to our environment. And Bin Laden might be a virus if we're extending this analogy. But we get back to allergy then. And what is allergy? It's something harmless. And this lady here, I don't know if anybody recognizes her. That's Cornelia Rau. She was a German tourist who came to Australia a few years ago and was having a mental health problem at the time, so didn't really represent herself well. And our immune system, which was ASIO, which isn't quite as evolved, took it upon itself to imagine that she was dangerous, not harmless, which she was invariably harmless, and banged her up in offshore detention. So that's an aggressive response, and Australia suffered pretty deleterious consequences as a result of that. We were a bit of an international pariah for some time. I think the British press had a riot about that entire affair from their little rain-sodden island. But Cornelia Rau kind of constitutes what allergy is, which is something foreign but harmless, where we're meeting in a funny circumstance and we think, actually, that's a dangerous thing. We mount a deleterious response and we have bad consequences for ourselves. And so that's what allergy is. Sorry, that's a joke. So what are the signals that the adaptive immune system uses to recognize a threat? Well, foreign versus self, and I won't really go into that. But then danger, there are lots of bits of things that can tell us innately that something is dangerous. So remember, I said E. coli is obviously something that we can recognize innately as being a foreign thing, as being a bug. And that's because it's covered in these bits that it can't change, and we have evolved to recognize. They're called PAMPs. Inflammation. If you get a bunch of damage happening on your skin or in your gullet or somewhere else, a bunch of damage happening, and something pops up, a new protein that you haven't seen before, in the context of some damage, you think, oh, okay, that's probably a bug, isn't it? And so those are damage-associated molecular patterns, or DAMPs. So bits of bugs and damage, and then the site of the protein. So if you see something in the mouth, could be a food. But if you see something elsewhere, probably not a food, because we haven't been doing things like rubbing foods on our skin over millennia, which is something we now do. And so the site of the protein is an important thing in terms of the immune system. The immune system in the mouth is very different from the immune system elsewhere. And then the quantity of a new protein, if something suddenly appears, then that's relevant as well. So how does all this come in to allergy? So allergy starts with eczema. in most instances, not in all instances, but the big driver, or one of the big drivers of allergy is eczema. We have the atopic or the allergic march, and that is when you get eczema first, and then you get food allergy in general next. Excuse me. When do you get asthma? Well, we get viral-induced wheeze, and John will have talked about it. When does asthma come from viral-induced wheeze, and when do we make that diagnosis? But we probably get eczema, then food allergy, then asthma, and then allergic rhinitis. It's unusual to see it before the age of 4, really, 3 or 4, to see sensitized allergic rhinitis. And that's the allergic march coming on over time. And so eczema is the first thing. And we used to think that eczema was an allergy, but eczema is actually not an allergy. One of the big clues to that was that the main genetic risks for eczema are filaggrin and SPINK5, 2 genes which are associated with dry skin. So filaggrin keeps your epithelial tight junctions together, and water crosses. If you have a mistake in filaggrin, if you have a polymorphism in filaggrin, which 10% or so of us will have, the ones with the dry skin, very possibly. And so filaggrin mutations probably constitute about 30 to 50% of risk of eczema, and they also constitute about 30 to 50% risk of allergy. So a huge amount of the allergy in the population is in people with these filaggrin mutations who have as their primary problem dry skin. So this kind of made us think again, how is it that you're getting dry skin is leading to eczema, but also leading on to food allergy. And in fact, the driver there is huge. If you get into teenagehood, so in small children, about 3 to 5-fold increase in allergies and asthma, food allergies and asthma. If you have a filaggrin mutation, if you're a teenager with a filaggrin mutation, you have about 30 times the amount of food allergies. So it's a big driver for your allergies, and it's all about dry skin. So what relates eczema to the allergic response? So this is why I've been going through this thing about danger. So eczema is dry skin, but then you scratch it, or you wear some tight clothes, or you go and you swim in a chlorine pool, or you do something else, you have a virus on board, something excites your dry skin, you're scratching it, now it's become red and inflamed and torn skin and broken skin, and now you've got inflammation, and inflammation is danger. Remember I said that? All this inflammation is telling our immune system this is a bit danger. And not only that, but I put in a picture here of this is just an epidermis here. Sorry, oops, let me just go with that. So this is an epidermis, and on the outside here with the stratum corneum, if that breaks and you get cracks, you come down into all these black cells, which are these immune cells, and they're all sitting there ready to get bugs that come down through those cracks. And you've all seen kids with eczema, and they have that kind of hyperlinear old man's hands, dryness, but it's cracking across the surface, and into those deep cracks come bugs. So if you've got all this inflammation, and then you've got these bugs which are acting as adjuvants, they've got all these bits that we innately recognize as bad, and into that comes some peanut or something, and suddenly you think, oh, okay, that's not crash hot, that's a combination that could well lead the immune system to make a mistake that might then cause it to become allergic. So how do we know this? Well, we can't do an experiment that puts allergens onto kids with eczema. That's not allowed. That wouldn't be fair. You'd be causing a lifelong disease for an experiment. But we can infer it. So you can use animals. If you get an eczematous mouse, a scurfy mouse, and rub allergen on its tail, it'll get some food allergy to that particular food. We used to give kids, we used to use emollients for kids, which were arachis oil, which is peanut oil. We used to put that on their eczema regularly, and the kids were all getting peanut allergy. So eczema effectively causes allergy, and it's probably the food arriving in that inflamed, highly inflammatory, highly immune situation that's the problem. So there's one of the things I like to say to people is don't put on eczema anything you might later rely on in your diet. If you're already eating it, you might well be protected, but if you're not eating something and it's going on your skin, that's not a natural thing. And do treat eczema hard. So eczema, the driver of allergy, treat it hard and try and treat it with non-food-based products if at all possible to prevent the allergy. So how does the food get on the skin? You're thinking, yeah, sure, this guy's thinking, how does the peanut get there? Because they're not going to rub the peanut on the skin, but peanut travels around the house, and there are lots of different experiments looking at this. And how the peanut goes from, there's one experiment, completely new houses, and they say, can we use your house? Would you do us a favor? Would you brush or put one piece of peanut butter toast in the morning, and then we'll come back in the evening. We'll look for that peanut butter everywhere. And they use hoovers, and then they use molecular methods like ELISAs or whatever to measure the small amount of peanut that they find. But they find it everywhere. It's on all the different surfaces. And so it does, definitely, it's quite tenacious. It travels around the house, and that may well be one of the reasons why some allergens are more common causes of allergy than others, although there are undoubtedly other reasons. And then, so there's another paper there looking at peanut in maternal bed dust is a risk factor for peanut sensitization. So the peanut gets around the place, the allergen gets around the place, and then it gets onto your bad eczema skin, and then you're at risk of inflaming. And in fact, there's, I haven't put it there, but kids with bad eczema who live in a house with peanut, and kids with bad eczema who live in a house without, they will get allergies. But the ones who live without the peanut don't get so much peanut allergy. So other than that, you can get other danger signals elsewhere. So we think you probably get danger signals in the gastrointestinal tract as well. There's a bit of working out to be done on this because people have been concerned that certain PPIs will cause allergy. There's been an association. We think probably it's to do with reflux itself and inflammation in the lower GI tract. But you definitely get more allergic sensitization in people who have that sort of a profile. There's one group that we have locally. We have one of our gastroenterologists has a big group of patients who've had repairs of tracheoesophageal fistula, which means that they've had this gap in their esophagus brought together, stitched up, and so they have no sphincter. So the food slips up and down, and they get esophageal burning from acid, and they got inflammation there, and they have more allergy. So we're pretty sure that allergic sensitization also happens due to this pro-inflammatory drive elsewhere. So that's what causes the allergy, what we know about what's causing the allergy. And one big driver is foods or other allergens landing on inflammatory pro-immune places. But what protects against allergy? So bugs. And in particular, bugs do a number of things, but they can probably signal safety. So if you imagine hunter-gatherer mums going around with their baby, I know how they would have done it in, deer skin or something wrapped around, and they would pick some food and they would chew it and they would give it to the baby. So there's always saliva on the food that's going to the baby. So a saliva is a pretty good indicator that you may well have been getting food that's from your mum. And so they did these experiments in several places again, the mummy dummy suckers, where the children whose mums, so these were all of the kids were using a dummy, and they divided them up, and they said, well, they didn't divide them up. They asked the mums, what do you do? So it's an observational study. They said, what do you do in terms of if the dummy lands on the ground? And mums were given choices of various things that they might have done. And there was a huge difference between the ones who took the dummy, sucked it, and gave it back to the baby, which was seen as protective from allergic sensitization and from asthma and from eczema, versus those who boil washed it and gave it back to the baby. So something about that is protective, and we think it's probably maternal saliva is probably carrying bugs across. Bugs we know already in a mouse environment, they skew away from a parasitic response, and it's a parasitic response, that Ig response. So I said I wouldn't say Ig, but there you go. That's the response we think is accidentally set off in allergy. And so if you take germ-free mice with no bugs, they have more allergy. Yeah? So having a few bugs around probably protects you to some extent. Children born by cesarean section, more likely to report wheezing, to have asthma, to have A to B, to have food allergy. It's probably about a twofold increased risk or thereabout. C-section is a sterile delivery, and you don't get mum's bugs as you come down the vaginal canal. And so, in fact, if you have a vaginal delivery and the mum is sucking the dummy, then you probably have an additive protective effect in terms of against the effects of getting more eczema. So, Further stuff about bugs, dirt in the house, that's a very good protector. So if you're in the dirtiest quartile of houses, you protect it against bugs, or you protect it against asthma, against allergy. Measured on GNB is gram-negative bacteria. So if you just measure gram-negative bacteria in your dirt, it's something I tell my wife a lot. Antibiotics in early life probably skew you towards allergy, again by altering your balance of bugs. So it's not just not having enough bugs, it's a balance of bugs that kick in there. Farm animals, there's loads of evidence on people co-living with farm animals, that's a protective thing. I know a lot of, there are certain lifestyles like the Steiner Waldorf kids, they have a lot of fermented foods and large engagement with animals, and they seem to have very low rates of allergic sensitization.
Pets as well?
Sorry?
Pets?
Pets. So pets are a bit different. If you have the pet from birth, like if you have a dog from birth, you're protected. If you get the dog after birth, there's probably a risk of dog allergy. So having it from birth seems to be an important thing. If you're going to have a pet, get it before the kids are born. And then, probiotics, and I'll talk a little bit more about probiotics, but probiotics seem to reverse the effect of a sterile delivery. So if you're looking at probiotics, what do they do and where? There's a huge literature, and I think I'll mention later on, it depends which probiotics, and we don't really know yet which ones to use. So I stick to a few where there's trial evidence in a certain context. But probiotics, if they help in any context, it's probably to reverse those people who have abnormal bugs already. And so C-section delivery is one where there seems to be evidence. So don't be too clean. Can more bugs break allergy? So that's two questions. And this is about probiotics. And I won't take any questions about poo transplants because I don't really know about them. And there isn't an evidence base in allergy at the moment. There obviously is in things like Clostridium difficile, and people are talking about them for IBD and stuff. But for allergy, we don't have an evidence base. But in terms of probiotics coming in to trying to fix allergy, there are two questions there. One is, can probiotics given at the time of giving a food break an allergy to that particular food? And can probiotics more generally help you with not having so many allergies? And so in the former, we think probably yes. There are a couple of trials that are put up there. This one here was an extensively hydrolyzed formula in kids with milk allergy. They used one of those formulas which is very, very broken down parts of milk protein, short peptides. And they gave those short peptides along with a probiotic. In both of these cases, it was Lactobacillus rhamnosus GG. And the kids who had the probiotic had an increase. This is the kids up here who had no probiotic. In fact, having the hydrolyzed milk formula in that study helped to reduce the level of milk allergy, although that is always a bit of a question. I don't think there's a huge database that says that, but certainly if you had the probiotics along with your bit of milk protein or broken milk protein, that helped you to get over milk allergy. And then there was, this one is quite famous study from Melbourne. This is looking at the PPOIT study, and this is peanut oral immunotherapy, where they give probiotics at the same time. My colleagues are often complaining that they haven't gone far enough and really proven their point, but I think their initial study, it wasn't a placebo-controlled randomized trial. It was a randomized trial, but it wasn't placebo-controlled. It was against historical rates of peanut allergy, so they're trying to break peanut allergy here by giving it with a probiotic, and their outcomes were really good. And I think everybody's being a little bit mean and not saying actually probiotics are likely to have a role in the future of breaking allergies and of reducing allergies, and that's in a specific way with the food that you're trying to break the allergy to or that you're trying to build tolerance to. So probiotics are probably what we call a positive adjuvant. I mentioned adjuvants, the thing that says this is a bad thing, you got to react to that. So you put an adjuvant in with a vaccine protein to say that this is a bad thing, I want you to react to that, and the immune system reacts because you put the adjuvant in there to tell it that this is a bad thing. A positive adjuvant works the other way around, where you put something in, a protein in, and you put something good in and say this is a good thing, I want you to not react to this, to tolerate this. And so probiotics are probably a positive adjuvant. But if you're trying to give something along with a food that maybe you've met somebody who's got a bit of egg perioral rash or something like that, or they've had a small reaction to a nut or something, and you think, I'd like to give them a small amount because I'd like them to not have this allergy long term, in particular for the smaller kids, where you've got that window where they seem to be very susceptible to inducing tolerance, then you might say Lactobacillus rhamnosus would be a reasonable thing to use in that context, along with your food. Is it a good thing in a specific way with a specific food? Is it a good thing more generally to give probiotics? It depends on the probiotics, and that's the problem, is there are millions of probiotics and people have their different formulations and are all going to make their fortune out of selling them. But do they relate to things that have been trialed in studies and shown to actually benefit? This study I particularly liked. It came out last year in the Journal of American Medical Association Dermatology. This was eczema, so you have to look at what is my outcome. And this was eczema, and between the cohort who received the placebo versus the cohort which received a complex mix of several different bifidobacteria and lactobacilli. Those things mixed together, so there's a specific thing in this paper, and that's different from other papers, but this paper had a really cracking outcome in terms of the reduction of their eczema in the intervention group versus the intervention group in orange there versus the placebo group in dark blue, in terms of their outcomes. So sometimes it's going to work. I think you have to look at the literature and you have to figure out, what am I going to use in an individual context? It's going to be a really complicated space, and I wish everybody luck with dealing with it. But that is how you have to do it. You're going to have to say, you're not going to be able to say, I think probiotics will work. In general, they're probably reasonable. If you had a C-section, say, yeah, some probiotics, but which ones do you use? It's a hard question at the moment. So what else? The bugs protect. So we reckon inflammation and eczema probably makes a problem. Bugs probably protect to a degree, or certain types of bugs. And then eating the food probably protects as well. So we previously had lots of guidelines which said, regarding food avoidance in early life, the WHO in 2001, that's this paper up there, said to avoid eggs and fish and nuts for certain durations after birth, and that was wrong. And so it turns out that eating a food is how the immune system learns it's a food, and that it should then tolerate it. So that's actually an important part of early life immune interventions for every parent. We know this. There are several things. There was initially some mouse data that says you could feed the mouse the allergen and that would protect them from allergy. Then there was this interesting study which looked at Jewish kids in Israel and in London. And they took Jewish kids because they were ethnically the same and therefore probably not genetically that different, and so reasonable comparator groups. And they found that the Jewish kids in Israel had a really much lower rate of peanut allergy. And they thought, oh, maybe it's because they all in Israel are eating this snack, a weaning rusk called bamba, which contains peanut from early in life. And so the team that recognized that then went on to do a cracking study, and I won't go through all this. This is the LEAP study, which has been sort of transformative in this space in many ways. Hard to replicate with other foods because they managed to get, they stuck at this for ages, and there was so much frustration that they weren't publishing their results, but they decided they wanted to get a good result, which is great. And also they introduced power into their study by recruiting a lot of kids with high risk. So they had a high number of the events happen, high number of kids with allergy. If you don't have a high number of your outcome event, it's very hard to compare it and get a statistical difference from the kids who haven't had an outcome. And that was one of the problems in the other study that I'll show followed this. But the LEAP study was terrific. They took high-risk kids with either eczema or egg allergy, and they then either gave them some peanut or gave them some placebo. The kids were between 4 and 11 months of age, median 7 months of age, and the outcomes were fantastic. This is whether they've had a skin test positive or not. They did exclude some kids. They excluded kids they thought would already have allergy by the time they were starting. But then they got to this group here, and if you take the entire group of whether they had a skin test positive or not at the start, then the avoidance group, who didn't get any peanut, had 17% peanut allergy, and the consumption group had 3.2% peanut allergy. So there was a major difference. But then, remember earlier on I talked about that house where they went in and they hoovered all the surfaces and everything. So this crowd did that as well. It was a bit sneaky of them, but they said to people, can we come around and check? And so they had this really fantastic way of seeing whether people were cheating or not, whether they were actually following through on things. And if they were actually doing it, that's the per protocol analysis, whether they could be judged to be actually doing it. The outcome differences were about 50 times as much allergy in the group that was avoiding peanut as in the group that was eating peanut. And so what we say to people is, look, just because you do it once isn't going to protect. This trial had regularity. It had not just an introduction and then that's it, you're fine. They had to do it regularly. So they were doing 3 times a week over a period of about 6 months. So that is the thing that you're going to say to parents then, is you need to do it, but you need to introduce the foods, but you also need to introduce them regularly. Extending that to other foods hasn't been so easily. The EAT study is from the same group, but their methodologies are not as good. And so they did a group of 6 foods here, and they again found a statistical significance for peanut in the per protocol analysis and egg, but they didn't find statistical significance for the other foods that they included, which was wheat and meat and milk was in there. I think all of this, cow's milk is a completely different thing, and cow's milk behaves in so many different contexts in a weird way. And so whatever I'm telling you here about eczema leading to allergies, I mean, it will do in some kids with cow's milk allergy, but cow's milk allergy just behaves a bit funny in comparison with everything else. But we think other foods probably by and large behave in a relatively predictable way. And the EAT study showed a tendency towards towards a benefit if you introduced all these foods early. And so we think probably introduction of all allergenic foods at a relatively early age is the thing to be doing at the moment. And that's, again, because of the effect of the specific food. This is putting together a meta-analysis, putting together a bunch of different studies that had been done on peanut allergy, on egg allergy, and these are forest plots. So I don't know if you're au fait with forest plots, but the diamond has to sit towards the side of decreased risk, and if it does, then that's protective, and the milk one sits across the middle. So we don't really know about milk. Maybe there's a mild trend towards a benefit with early introduction, but nobody's quite sure with cow's milk. But egg and peanut we're pretty sure about, and then other foods I think we're pretty confident that likely it's going to turn out that way. I just put that one in because people are often asking, what about celiac disease? Would that help? It doesn't. Celiac disease is some other mechanism, very well worked out, but not to do with the timing of introduction. And then we thought the LEAP study was the end of the story for peanut, that yes, you have to get it in early. And there is this little addendum, which is this paper, which people are a bit flabbergasted about, because it was a bad study. The LEAP study was marvelously done and has great and truly verifiable outcomes, but it didn't answer the question of what if the mum is eating the peanut or not eating the peanut? Does that make a difference? And this study from Canada, which was a post hoc analysis of a study done for other reasons, so it's hard to trust this data very well. They had quite marked differences. So it said if the baby ate the peanut and the mum ate the peanut, there was very, very little allergy. But if the baby ate the peanut in that third box there, if the baby ate the peanut and the mum didn't eat the peanut, then you had cracking amounts of allergy. So I'm not sure it's a real study, I'm not sure it's real data, but for the moment, anytime I get a parent through, I'm saying, yeah, you've got to eat the peanut as well at the same time. I think that's a pretty natural thing to do. So that's about the specific foods. Is general food diversity important? Well, there are lots of studies now. I put up 2 of them here, which is about 3,000 kids. These are birth cohorts, so really it's hard to say what food diversity, because you can't again randomize kids to get, you're going to have a diverse diet, but we're going to just give you a little bit of rickets or something. You can't really do an ethically approved study to narrow down their diet. So you just have to observe and see whether there's a difference, and any observational studies in this field are always affected by reverse causality, which is this statistical concept, which means that the parents who know that their older child has allergy or their cousin has allergy, and therefore they're at more risk of allergy, they will behave in a different way, and they will affect your statistics coming out the other way. So the answer that you get may actually reflect the biases of the parents because they're scared. And so that's reverse causality. So you have to take these sorts of studies with a pinch of salt. But they do come out and say, all of these studies look at dietary diversity, and what they say is that children who have a restricted diet will have a 2 to 5-fold increased risk of allergy or asthma. And so we're not quite sure why that is and whether it's reverse causality. In that bottom emboldened line there, 0 to 7 food items, and over here under, this is allergic asthma, and it's 4, and non-allergic asthma, I think, is it? Oh no, that is, I just did not, 4 to 5 times as much allergic asthma if you're in the group with a restricted diet. And so, not quite sure what that is, or why that is. Okay, fantastic. But it's probably real. So don't restrict your child's diet for either of those reasons. So what causes food allergy? And this is what we've been discussing. Dual exposure hypothesis suggests kids don't eat the foods that are around them. That's a problem. And that's actually bizarre. So for the first time in human history, kids are around foods that they're not eating. So if you think about it, it's like an analogy would be, you're sitting out there, you've just been hunting the woolly mammoth on the Mongolian steppe, and you're sitting around a campfire, about to eat the mammoth, and Mum will say, actually, can Johnny not have the mammoth? Because he's worried about the great cull and the mass extinctions. Like, is there a vegetarian option? And Dad might say, oh, but could we have some mammoth fat? Because his eczema's playing up a bit. And those are really weird things to be doing, to be not eating food that the child is around. It's the first time in recorded history, and it's only been around for about 30 years. Oh, shut up, eat it, that's it. And that was the story when I was young. And so I think we've come a long way in terms of a very strange behavior. And then the food that they're not eating lands on their eczema, and that's part of the problem. So I mentioned the peanuts in the house of the children, who then go on to develop peanut allergy. So peanut being around is part of the problem. And then if you put people on elimination diets for eczema, that can be a big cause. And we used to see a lot of these kids whose eczema was managed by elimination diets. Now, you will probably come across somebody where milk or egg or wheat, possibly. Those 3 big ones, they might have now gotten an allergy, which is worsening their eczema. And you think, God, what am I going to do? And you take out some milk and they get better. And then the trick is not to take out all the milk if you can. You take out a lot of the milk, but you keep a bit of that cow's milk protein in their diet so they don't become allergic to it over time. Because there are lots of examples of kids on elimination diets for eczema where they then reintroduce the food and they end up getting anaphylaxis, including dying from anaphylaxis to the food that was previously tolerated. So don't restrict your child's diet to treat eczema. You're confusing the immune system. So then, what's making the eczema worse that could be increasing the prevalence of food allergy? Well, we talked about the balance of bugs. Bleach baths seem to help a bit with the balance of bugs. They kill Staph aureus to some extent. So bleach baths is something we use a fair bit, although there's a question now, there's a paper came out recently that maybe it's not bleach baths, maybe it's baths per se. Maybe it's being a little bit cleaner, not using irritant soaps, but maybe being a bit cleaner with those bugs in your skin is possibly a thing. Pollution probably plays a role with allergy. Rarely you get a worsening of allergy based on food allergy. So you've had this eczema, you then make an allergy, it then worsens your eczema, which then causes you to get in a bit of a cycle. And in that case, it might be valid to remove a food, but we would always do a short trial of that food because we risk causing an allergy to the food. And then aeroallergens. You were talking to John about what are the aeroallergens, where are they getting involved in this story? And John was talking about, well, if you exclude them from the area, it doesn't seem to help a lot with your asthma, but probably that's because it's really hard to exclude them. So people put these tags on kids and adults going around the city, and this is Ewan Tovey at Sydney Uni, and they then looked at the dust mite exposure through the day, and about 25 to 30% of it was in your bedroom, which is where you do all your food, all your modifications, but the rest of it was on public transport or in carpeted rooms, in carpeted classrooms, or in cars. And so exposure is pretty, so actually clearing out those aeroallergens is really hard to do. But another forest plot for you, this was looking at eczema. We know that asthma is made better by immunotherapy, by getting rid of aeroallergen sensitization. We know that allergic rhinitis is gotten better by immunotherapy, by getting rid of aeroallergen sensitization. And eczema itself, so despite the fact that eczema starts off as a skin disease, some of them, and the numbers are always equivocal on the eczema trials, they're always slightly better, and that's because some of them just have really, really dry skin, and it's not an allergic driver, but some of them start off with really, really dry skin, and then they get their superimposed aeroallergy, and in particular house dust mite, and then that probably drives them on to get, and they're the people with diffuse eczema all over, or if they're wearing tight shorts, they might even have a sort of bathing suit area that's okay, and then their legs are not okay, and those sorts of things, and you're kind of thinking, oh, that's a pattern that looks like it's made by some sort of aeroallergen, and so probably they play a little bit in. So this is a thing that I show to a lot of parents, and this is to try and convince them to do two things: to eat the foods if they're not already allergic, and to treat the eczema hard. So food, up at the top here, you're eating a food, you eat it, it goes in the mouth, immune system says, is this a bug, is this dangerous? Well, it's in the mouth, it's a protein and there's no inflammation. That's likely to be a food. Use it again, and it gets pretty confident that's a food, and now it's going to tolerate it. If you don't eat it, and you have eczema, now it's on the skin, it's not in the mouth. You haven't seen it before in the mouth to learn that it's a food, and there's lots of inflammation because that's what your eczema is. And now, oh, that's probably a bug, isn't it? And then you see it again, you think it's a bug, and this is the signal that then leads you to react as if it's a bug, as if it's a parasite, and that's food allergy. And so if you can eat the food, and if you can't eat the food, then treat the eczema hard. And okay, I was just going to skip over a few things which I think are just would be useful. That's the end of that kind of story. So immediate type allergic reactions, and just differentiating them from a few other things. So a bit of practical stuff. Immediate type reactions tend to happen in less than 60 minutes. Occasionally you get delayed type 1 reactions, but mostly it's all that skin stuff with the urticaria and angioedema, you're itchy, you might have diarrhea or vomiting or tummy cramps, and then if you get anaphylaxis, by our criteria in Australia, it's cardiovascular or respiratory involvement. Cardiovascular involvement, I often describe it for the parents as from up in your airway. It's not just swelling of your lip. Respiratory involvement is not just swelling of your lip. It's your swelling of your tongue. It's anything that's going to obstruct your mouth. Kids that are gagging, a lot of kids drool, and that's often a sign of anaphylaxis. And then things that block your throat, so stridor, and just describe the sounds to them. A hoarse voice or a persistent cough. And what we see most commonly in the kids who have anaphylaxis in the context of our food challenge setting, which we see a few of every week, they commonly sit there and they look terrified. And that's because they're having that feeling of impending doom that people talk about. They're looking terrified and they're having a persistent cough, and then you give them the adrenaline and they look very happy again. And so those are the things we see most commonly. We then often see the rash, the swelling, all those objective features that tell us this is an allergic reaction coming afterwards, which is a bit of an unfair thing. Hypotension we don't see much, except we see floppy infants a lot, and then for parenteral allergies like drug and sting, we see hypotension a lot. We see less of that with foods. Those are the features: urticaria, angioedema, vomiting, and then if you're having an anaphylaxis, much more commonly a respiratory, often a lower respiratory one. So if you see somebody who looks terrified, you think they've had an allergy, auscultate the chest, like as not they're going to have some wheeze down there, or reduced air entry overall, and then cardiovascular changes. The allergens, they're almost always the same. There's about 8 foods: milk, egg, soy, wheat, fish, nuts, and then have I put down Sesame at the moment, and kiwi would be two other fairly large ones that we tend to see within our population. That's pretty much it. Allergy in small infants, you don't have to go looking very far. It's rare, you know, it's almost never additives. It's rarely other types of foods outside of these ones, unless those kids have shocking eczema. Then they can become polysensitized to a lot of things, and those kids can be more complex in terms of their allergies. The kids tend to have egg, milk, wheat, soy, and those ones. And then the adults tend to keep your peanut and your tree nut allergies. About 80% of those persist into adult life, although that depends on the definition. Somebody who comes and presents with bad peanut allergy will keep it. But we're now realizing that there's a group of kids with very mild peanut allergy in the first year of life that may well lose that by the age of 3 or 4. And then adults often pick up a fish or a shellfish allergy as they go through childhood and into adult life. And then egg and milk and wheat, they almost always go away. So there can be quite a long tail, so it might be into the teens, but they almost always go away, egg and milk and wheat, 80-90% sort of remitting. So the predominant tool, as John said, is history, and then you might do some skin testing or a RAS test, and then the gold standard test for allergy. Obviously, if somebody comes with a solid history, that's good enough. But the gold standard test for seeing whether they have an allergy or whether they're persisting with an allergy is a food challenge. And there's some skin testing, and I probably won't go through that at the moment. And I just wanted to, a few things there. Cross-reactivity, eggs. If you're thinking, is there an egg allergy here? You probably have to think, is this person got a peanut allergy and a tree nut allergy? About a 25% overlap there. Peanut and tree nuts. I would say the majority of kids that we see through with peanut allergy or with tree nut allergy have the other one as well. Cashew and pistachio always coexist as allergens. 90+% will have both of those. Walnut and pecan less frequently, but about 70 to 80% they overlap as well. Then there are certain milder allergies, although latex allergy can be severe, but as can kiwi fruit, but these tend to group into this latex group, and they can commonly be mild allergies, an oral allergy syndrome rather than an anaphylaxis risk. And I'll just quickly mention FPIEs because it's a more common thing than anybody understood. So FPIEs, food protein-induced enterocolitis syndrome. This is not a type 1 allergy. This is not an IgE-mediated thing, but it's something you guys need to know about. It presents in early life. Symptoms happen 2 to 4 or 5 hours after food. Sometimes a little shorter duration as well. We've seen kind of a half an hour to an hour. And then there's just profuse diarrhea and vomiting. The child becomes floppy and lethargic. These kids often get a septic screen. They sometimes make it to the ICU because they have third spacing and they look quite sick. There isn't a report of anybody dying, but it's an important thing to recognize. And the most common thing is rice in our population, and then cow's milk, soy, and egg I haven't put there, oats overlapping with rice, and poultry. So the implicated foods are a bit different, but thinking about that entity, diarrhea and vomiting, it's the second time they've had gastrodoc. I don't know what it is. Did you feed them the same food in both occasions? Okay, there it is. It's rice FPIEs. And then eosinophilic esophagitis. This will be my last slide, sorry. And this is an entity which, again, wasn't reported until the mid-90s. So people have gone back historically to say, was it there on biopsies taken for gastroesophageal reflux back pre the mid-90s? And it probably was, but probably not at the same rates. It's heavily allergic associated in terms of being strongly associated with skin test sensitization and happening in allergic individuals. In small children, it's really hard to diagnose because they don't report dysphagia, they don't report difficulty swallowing, they're often failing to thrive, and that's commonly the most common thing. They may be vomiting. It requires to be diagnosed on a biopsy, so you have to have a high index of suspicion. So a failing to thrive child who is vomiting, who had some reflux. Sometimes they respond to reflux medications, so that's a tricky thing. And if you let it go for years and years, they end up with this remodeled esophagus which needs dilatation, and it's quite ugly, and the adults who've been diagnosed retrospectively from having biopsies early on that showed eosinophils, they've done far less well than their equivalents who had biopsies where they got a diagnosis of GORD without any eosinophils. So the eosinophils make a difference going forward in terms of what your likely outcome is in terms of esophageal dysmotility. And the treatment, Losec first up, or PPI, swallowed steroids, so a non-absorbable steroid, usually in a slurry, that just coats the esophagus, and then an elimination diet can be used in some instances in this, and this would probably be our most common use of an elimination diet in allergy, other than eliminating the specific food that the child's allergic to. And yeah, that's just showing that the most common cause of of EOE is milk, and it's often not sensitized on skin testing. That entire slide shows that one point, that it's not sensitized on skin testing. So it's a bit of a different mechanism and a hard one to pick, and you just have to have a high index of suspicion and know about the entity. As they get older, dysphagia, esophageal dysmotility symptoms, they become much easier to elicit. In small kids, they just fail to thrive. That's it.